We're going to talk about musculoskeletal disorders. And first, starting with assessment of musculoskeletal function. So, this is just kind of a generic overview of things that we need to do assessment wise. Obviously, when we get into the different disorders, that's going to be a little more specific, but just general things to keep in mind for assessment. You definitely want to get a history of is this something that is an acute issue that may be like a fracture, or is this something that's been more of a long-term issue or could be a long-term issue if we don't address it. Get a physical exam or do a physical exam, just physically check them out. And then, of course, there's different diagnostic tests. They can range from fairly simple to a little more in depth and looking at um, structure and the bone placements and things like that. So, diagnostic tests, we can do x rays, we could do bone scans, we could do bone and muscle biopsies, electromyography, arthroscopy, ultrasound, or MRI. When we talk about health promotion and risk management concerning the musculoskeletal system, a lot of this is really going to go back to thinking about the child's ability and their developmental milestones and their progression of those and doing a thorough assessment. So, and just thinking about safety, so injury prevention, right? So, health promotion for children focuses on thorough assessments, especially at those health maintenance, those well child visits, assessing the child's ability to achieve those developmental milestones. So, really looking at gross motor, fine motor abilities. We want to screen for musculoskeletal disorders like scoliosis, especially in the prepubescent child and adolescent. So, even though we start roughly around age 8 screening for scoliosis, that continues until the child is done growing, which again can take till adolescence. So we've talked about that before. And then, of course, a lot of this turns to safety too, right? So safety precautions, that anticipatory guidance that we're giving during those well child visits is really important to educate parents. And as the child gets older, they can be educated as well to help minimize the risk of injury. So parental and child education, really important about use of bike helmets for bike riding, protective gear for organized sports, even though it's not listed, even thinking about where the child sits in the vehicle. Do they need to be in a car seat, a booster seat, or can they use the safety belt of the car? So again, depending on age and development and all of those things, that would make a difference, right? And then, of course, nutrition is really important. Nutrition is important. We want to make sure we're ensuring adequate calcium, vitamin D intake. That's going to help with bone growth and healing. So, if the child would require bed rest, calcium intake should also be moderated to reduce that risk of renal calculi from forming because of the the immobilization for whatever reason they're on bed rest. And teenage years, important for both males and females to build calcium stores to protect against osteoporosis later in life. All right, we're going to talk about therapeutic management of musculoskeletal disorders in children. We use a variety of methods as therapy that could be cast, traction, distraction. That is not the same as distraction like using play or TV or music to distract a child from what's kind of going on or help with pain. This is a different type of distraction. This is usually an external device, oftentimes to help with bone growth for various disorders. So it is something that we medically do to fix whatever our particular disorder is. And another one is open reduction. It's not listed, but even closed reduction can also be another management method. When it comes to casting, casting is used to treat a wide range of disorders. They can be for simple fractures to more of correction of congenital structural bone disorders. When we talk about cast application, those are usually cast application. It's either the use of plaster of Paris or fiberglass cast. There's benefits to each one, right? Benefits and negatives. For fiberglass, it's more lightweight. You can get it in a variety of colors, not just plain old white. It can be immersed in water as long as a special waterproof lining has been used. The disadvantage, it is more expensive and it may not be practical for different disorders that we do what's called serial casting. So we'll talk about serial casting, especially with club foot, disorder or congenital clubfoot disorder, and that's where the child wears a cast for a short amount of time. As soon as we take it off, we do the manipulation, what we're trying to do, and to straighten the foot for clubfoot, and then we'll apply another cast. So they wear these casts for short periods of time. Doing something like fiberglass, because it's such more expensive, may not be the best option, right? So again, there's different methods and different advantages and disadvantages, regardless of what type of cast you're going to be using. Children need to have an explanation of what's going to happen or why we're doing this in a developmentally appropriate way that they can understand. So, and that it's really meant to help align body parts. It's helping fix whatever our issue is for that particular child. The healthcare provider might have to um, kind of pull on a body part during casting. So you need to prepare them for that, right? What it's going to feel like. Is it going to be warm? Is it cold? We're not doing anything that's going to necessarily be painful, but the unknown to a child is scary. It's always best to allow a support person, if at all possible, to accompany the child to a cast room. That can just help kind of ease their anxiety and their fears. They can hold their hand, they can talk to them, um, give some distraction or whatever the case may be. Before the cast is applied, we usually put what's called a stockinette on them, so it's kind of like a tube cloth material that stretches, and it stretches over whatever area we're going to be casting, and then it's wrapped with a soft cotton padding especially over bony promises, and then the casting material is applied. Where for plaster of Paris, it's a cheaper casting material, but it's really heavy. It's not water resistant. It can take a long time to dry, anywhere from 10 to 72 hours. Again, depends on the size of the cast. Um, the casting material itself will feel warm from the chemical reaction, in order for it to start working. For the We get it wet and it creates a warm sensation to the child. So it'd be important to tell them it's not going to burn it, but it is going to feel warm. The wet plaster cast also has to be, while it's drying, needs to be supported by a pillow that's covered with plastic. You would not want to grab it by like your fingertips, like if you're repositioning them, because that could create indents on the cast, creating pressure, which then could put pressure on the skin itself. So you'd have to be very careful with that. And of course, like turning it so that it can get air movement and dry. Fiberglass is a lot more faster drying. It only takes 5 to 30 minutes. So again, another advantage with the fiberglass. And in some cases, they may need to cut what's called a window, that's placed in the cast, and that could be because maybe we have infection that's suspected and we want to be able to observe that area. If it's a child who has a body or a hip spica cast, they can do what's called windowing or cut that window to prevent abdominal distension. It also allows nursing to be able to assess bowel sounds. Um, they also will window out, especially over the private area, the genitals and the buttocks, so that child can go to the bathroom. May have to modify it depending on the size of the child or the age of the child. If they're potty trained, they're not going to be able to go sit on the potty. So there's different things that we can do for casting. Of course, when we cast somebody, there are some assessment pieces that we need to be doing, and something that we're actually looking for or wanting to prevent from happening, and that's compartment syndrome. So we'd want to be assessing what we call the 5 Ps. You should already be familiar with that from med-surg, but with compartment syndrome, it's when the cast or whatever type of dressing becomes restrictive and it puts pressure on that enclosed space. So that pressure can actually result in severely decreased blood flow that potentially threatens or damages and causing necrosis of the surrounding soft tissue and nerves. So you'd want to assess fingers or toes carefully for warmth, pain, their function after application, and we usually do that at set intervals according to physician orders. And we can always teach parents how to do that too when they go home in the beginning. If there are signs of compartment syndrome present, the cast needs to be released immediately to try and prevent any further nerve or tissue damage. And in some cases, We may need to do what's called a fasciotomy, which is surgically opening the compartment. So, especially if it's muscle that is involved, like on the leg, and there's so much swelling there from whatever the injury is, and then we have a cast on, we can cut the cast on off. But in some cases, if whatever the injury or surgery that we've done is creating a lot of swelling within like a muscle, sometimes they have to go and open that up or do what's called a fasciotomy to release that pressure because of all the swelling. So, the assessment of fractures, again, we use the 5 Ps: pain, pallor, paresthesia, paralysis, and pulses. So, I highly recommend knowing what is a normal finding, what is an expected finding for those 5 Ps, and when is it a time that we need to actually report. So, again, that should be something you're already familiar with, but you would need to review that because that's something that's really important to be assessing for. Now, when we talk about cast care and our nursing care, really important things that we need to be doing or assessing for the child who has a cast. And then one of those is keeping that extremity elevated on a pillow to help prevent edema. So make sure you're properly elevating. We would want to elevate above the heart if at all possible. Obviously, if they're up like walking around, like if it's an arm, that's a little bit harder. We don't expect them to carry their arm above their head, but putting it in a sling and properly positioning it even in a sling. So, but if they're sitting down or laying down, try and position that extremity or elevate it to an extent a little bit above the heart to help prevent some of that edema. We want to check circulation frequently. That could be, it depends on what the physician orders, but that can be, especially after the cast is initially applied, that could be every 15 minutes for the first hour, every hour for the next 4 hours, and then at least Q4 hours throughout that first day. And again, what we're doing is we're assessing those 5 Ps for our neurovascular function. We want to look for signs of impaired neurovascular function. So again, pallor, pulselessness, pain in the casted part, paresthesia, paralysis. Children who are younger than 6 to 7 years of age have difficulty describing paresthesia. So they may just kind of whine or cry in discomfort of sensation. Sometimes you can, if they've ever had 6 and 7, still can be a challenge, but if they've ever had like their foot or their hand fall asleep and it kind of feels like something's prickling them, pins and needles, you can try and describe it like that. When it wakes back up, is that whatever the casted part is, does it feel like that? Edema that doesn't improve with elevation is an important sign as well. Again, thinking about compartment syndrome. Any of these symptoms require immediate attention because that tells us there's neurovascular impairment that, if we let it go on, could lead to nerve ischemia and destruction, which could possibly lead to permanent paralysis of the extremity, and we certainly don't want that happening. When you have somebody who is in cast, especially a cast that's around the genital area, we're trying to prevent flow of urine to the edges of the cast, especially when they're not like full body length or the high leg cast, and a child who's not toilet trained. So if the cast kind of covers around the genital, not over the genital area, but around the genital area, we typically cover the edges with a plastic or waterproof material to help keep it dry. We also like to keep the child in a semi-Fowler's position by using pillows, raising the head of the bed to help direct urine and feces downward away from the cast. And a lot of times we'll teach parents how to diaper the child in ways to try and prevent the cast from getting wet. Uh, if you have a younger child who has a body cast, use of like bib or some sort of covering over the top edge of the cast, that's just so when they're eating or drinking food and fluids don't spill in there, because those little pieces of food, you can't get them back out. It can actually mold and macerate or irritate that skin, break it down. And we don't want to do that or have that happen. As well as we want to be careful about what kind of toys they play with, because we don't want something to come off or small parts to get dropped down inside. Again, that can cause irritation, create a pressure ulcer. We have a whole different issue. It'd be important to teach parents, make sure they understand how to properly position the child and extremities. So again, a sling for upper extremities, lower extremity, understand the amount, how much weight bearing they may be allowed on the affected extremity. If it's partial weight bearing, if it's No weight bearing. Make sure that they understand what is the restriction, if any. How to use crutches safely if those are prescribed. And again, whenever we're handling large casts, you want to make sure you're modeling good role behaviors and moving the child around. So if the child has an abduction bar, which is like a bar to keep um, like the legs separated, I have a picture here in a couple of slides that'll show you that. Um, that bar should never be used as a handle for lifting because the bar is not there for lifting and transfer, moving the patient around. The bar is there to keep them abducted, right? So over time that bar could break if that's how it's being used for lifting and moving, which then weakens its support. It's not doing its job that it's supposed to be doing with that cast. Make sure parents know to use good body mechanics. Help them find ways to move the child from room to room. Um, a child typically thrives on having some sort of touch, being touched. So, head and arm stroke, demonstrate how the child can be held or cuddled and supported with these different types of casts. So, in the next slide, I'll actually show you some of the different types of casts that we use. Children also need to make sure, or not make sure they report, but if they are having sensation, they can report that. And we can teach parents how we can, or how they can um, help the child with that itching sensation. So if an area immediately underneath the edge of the cast is itching, it's probably just a result of just some dry skin. If they can reach their hand or fingers underneath the cast, edge of the cast, massage that area, that can help relieve the itching. Applying hand lotion may also relieve that dryness. Again, that's just at the edge of the cast. You don't want to stick anything down the cast to relieve that itching. Um, Especially think about if you've ever broken your arm or for some reason we're in a leg cast. The farther down that itching is, yes, it's bothersome, but we don't want to stick anything down that. I've heard lots of using pencils that obviously they have lead, so the lead then breaks. Using coat hangers. The problem is you don't know how, or the child doesn't know how hard they're scratching. They can actually cut their skin open. Again, like leaded pencils, if they break, that doesn't come out. Again, we worry about um, pressure in an area or skin breakdown. So, really want to prevent them from doing things that aren't safe. If it's an area that's unreachable, we can try blowing cool air through the cast with a fan or a hair dryer on a cool setting to relieve some of that itchiness. Again, not using coat hangers, knitting needles, pencils, things like that to scratch the area because, again, it can injure the skin and lead to an infection. I definitely recommend also looking at cast care at home, reviewing that box in your book, things that you would want to go over with the family and teach them. So this slide is just a variation of different types of casts that we may use, and you can see that some of these will definitely present a little more challenge than others. So, like the full spica cast, where both legs are covered in casting and even up to the child's chest. And then we just have a little cutout or that window I was talking about around the child's genitals and their bottom. We even have half spicas or a single spica where it's just one leg. Again, you have to think about the young child, again, with toileting, or again, we don't want them sticking things or having food fall down in the cast from eating and drinking. Oftentimes, too, with is how high these come up, they can't sit up in a chair like a normal person or child would. So again, you have to think about positioning. You also have to think about how are we going to safely transport them, right? We have to sometimes have modified ways that we still safely buckle them in, but you can't put them in a car seat. You can't put them um, in a regular seat if they're big enough as well either to sit like on a bench seat or a bucket seat. Those casts don't allow for that, but we still have to provide safe ways of transportation. There are different devices out there that we can use to help modify the car, either modified car seats or other devices that will hook into uh, the car seats buckling system to allow for safe transportation of the child. No, you cannot just throw them in the back of a van. with a bunch of pillows and let them just roll around. That's not safe. So there are some other modifications that we do have to take oftentimes with these casts. So this is just an example of a spica cast with hip abductors, those bars I was talking about. I know this picture is a little dated looking, but what I like about it is one, you can really tell. Look how with those two different bars, she's got one being an older child, she's got one up the thighs and she's got one down closer to her ankles, or not the calves, but the top of her, like her shins, basically. Again, those are not used for lifting or being able to reposition them or move them. That's not the purpose of those. Those bars are meant there to keep them spread apart or be abducted. Um, but notice too in this picture, look, her legs are spread wider, especially at the bottom, than that wheelchair. So again, you have to think about logistics of being able to transport them and move them, as well as she's not all sitting all the way up in that wheelchair. She's actually reclined a little bit. So again, think about the transportation or where she's going to sit at home that's going to be comfortable. The other thing I like to point out is she has a little Cabbage Patch doll. And notice that the Cabbage Patch doll is casted similar to her. Oftentimes we do that as a way for kids to be comforted, so they have something that is just like them. So oftentimes if there's a favorite stuffed animal or a doll, we can cast them in the same colors so they have something that is just like them to give them comfort. This is just an example of kind of the process of applying a cast. Even though they didn't, in these pictures, they didn't use any sort of stocking net material, they did wrap it with a cotton gauze to protect that skin. And then once they're done with that, then they usually will actually apply the cast um, for however long they need it for. We talk about cast removal for the child. A cast can remain in place from anywhere from 4 to 6 weeks typically. And when we go to remove it, it's removed using an electric cast cutter. And that electric cast cutter can be really scary for the child. It's loud, it's going to cause a lot of vibration, so it's frightening. We definitely want to make sure we kind of explain what's going to happen, what it's going to feel like, that there's going to be a lot of noise and it's going to vibrate on their skin. Because oftentimes kids, when they see that, they have a fear. The sound of the cutter alone is scary, as well as they often think it will cut their own skin. So some things that we can definitely do is demonstrate removal of a cast on a doll or parent to show that it's not going to cut their skin. Oftentimes too, we need to tell family or child their skin's going to look macerated and dirty after the cast is removed. Just a good bath, good washing it will wash away a lot of that. And oftentimes, if it's like an arm that was casted in a flexion position, it might feel a little stiff or even sore the first time they try to extend it. Children often will continue to use their extremities with caution even after a cast is removed. Again, just because it's a little stiff and sore. Important to advise parents to allow the child to begin using the extremity at their own pace. It's nothing that they need to push them to do. And once healing has taken place, that extremity is as strong as it was before the fracture. Another form of therapeutic management that we can use for musculoskeletal disorders is traction. And there's two different types of traction that can be used. There's skin traction and there's skeletal traction. But the point of traction, regardless of which type you are using, is to reduce dislocation and usually immobilize fractures. So it usually involves pulling on one body part in one direction against a counter pull in the opposite direction. So there are different types of traction. Again, there's skin and skeletal traction. Skin, an example of that would be like Buck's traction, if you've ever seen that. Skin traction is where the extremity is wrapped in a material like an elastic bandage and then suspended from a nearby pole or frame so that the weight of the body produces the traction. Right? So there's another weight on the other end, kind of like in this example, even though it's kind of more of a cartoonish type drawing. That's a great example of skin traction. And then there's also skeletal traction. And skeletal traction is where you have pins or wires that are going through the skin into bone. And then there's ropes strung over pulleys and attached to weights to exert that pull on the extremity at the pin site. So really important thinking about pin care and assessment. So with our pin care, we would want, typically there's cotton gauze squares that are placed around the ends of the pin on the outside. You would want to assess those daily for any sort of drainage, excessive odor, or any local erythema around that pin site. Those could indicate signs of infection. Typically, we clean those pin sites with half strength peroxide and using sterile technique. And then, if it's ordered, an application of an antimicrobial um, type antibiotic ointment like bacitracin, neosporin, something like that to help prevention of infection. So it just depends on what is ordered. But really important thinking about your skeletal traction, looking for those signs of infection. An early indicator, too, could be an increase in their temperature. That might be an early indicator versus actual physical signs that you see. So, really important in doing good assessment when you have skeletal traction. Thinking about your traction related care, there's other things besides obviously, caring for the traction itself. Um, there's other nursing things that we need to be assessing. So we need to assess neurovascular impairment. So again, think about your 5 Ps, right? So assessing the extremity and traction potentially especially when you first put them in traction, every 15 minutes during the first hour, and then every hour for 24 hours, and then it can go typically to Q4. So part of what we're doing is, again, our 5 Ps of the neurovascular assessment. Traction can as well lead to hypertension because of the head typically being positioned lower than the um, lower extremity. So it'd be important to assess that every day for that possibility. Not too often that you see that in kids as much, but it is certainly a possibility. It just depends on what kind of traction they're in and how they're positioned if that's an issue. We want to make sure we're providing good skin care. So back, elbows, their heels can become irritated from friction against the sheets. So use of a trapeze bar that's suspended over the bed can provide mobility and assist children using bedpans or positioning themselves in bed. Child life specialists and volunteers are really helpful. They're helpful keeping the child occupied and distracted. They can give them or get them a use of a wireless computer or texting can be important to help them maintain that contact with friends and family. You still want to encourage frequent visitors to help maintain those peer relationships. That would be really important. An assessment and maintaining traction and position at all times. So checking to make sure your weights are hanging freely, assessing for infection, assessing for pressure ulcers with skin breakdown, assessing for pain and spasms. I'll get it out. Important to make sure we're still keeping that child comfortable. We want to also make sure we're keeping small objects out of the bed, the cast, or the boot that we are using in traction. Again, making sure we have age appropriate toys. We don't want small toys. You want large, visible toys. You want to remove any toys before nap or bedtime. And then also want to assess their ability to eat and drink while in the recumbent position. Right, the first disorder we're going to talk about falls under our infectious and inflammatory disorders of the bones and joints, and that's osteomyelitis. So I'm pretty sure you've talked about osteomyelitis before, so this should not be new. But osteomyelitis is infection of the bone, right? So infection of the bone. Staphylococcus aureus is the most common causative organism in older children, where Streptococcus pyogenes is more common in younger children. There are two different types of osteomyelitis, and that's acute hematogenesis, and there's exogenesis. So acute hematogenesis means it's a blood-borne bacteria that causes an infection in the bone. So could be a result of extensive impetigo from a burn or even a skin abscess. Where exogenesis means there's a direct inoculation of the bone from a puncture wound. So open fracture, surgical contamination, or even adjacent tissues. Assessment-wise for osteomyelitis, it usually begins with acute symptoms. Then they will develop more systemic symptoms, have malaise, fever, irritability, sharp pain at the metaphysis site. And by the second day, they will develop tenderness and warmth at the site, edema over the bone, and that edema is because there's reduced blood supply to a large expanse of the bone, which can lead to death of the bone tissue. Our diagnostics for osteomyelitis, typically we can do an x-ray, and that will show what's called sequestrium, which is an important marker for diagnosis. However, on early x-ray films, those x-ray films can actually appear normal, so usually within the first 5 to 10 days. So it doesn't actually reveal those bone changes, or what we call sequestrium. And the sequestrium is just there's dead bone tissue that appears on a dense x-ray. So I have a couple slides that'll show you that here in just a little bit. But again, early x-rays can actually appear normal because there's not enough tissue or dead bone tissue to show those changes. So if we did an x-ray and it appeared normal, we could go on and do an MRI that'll actually reveal if there's infection that has also spread to nearby tissue, soft tissue. We can even do blood studies as well, and looking at white blood cell count, C-reactive protein, and a SED rate. Again, thinking about, white blood cells would be increased because you've got infection or bacteria present. Your C-reactive protein and your SED rate just tells you that there's inflammation occurring. We can also do blood cultures, and that's really just to look for that offending organism so that when we do management, talking about therapeutic management, we can target the right antibiotics for the offending organism. We can also do CT scans. Those can help show us really more the early bone changes when those x-rays appear normal. So this slide is just a comparison of what a normal tib fib should look like versus if you did x-rays and there was osteomyelitis present with a tib fib. And again, these are more severe cases. You don't typically see it quite this severe, but you can see those changes on the x-ray because of that dead bone tissue. So on this slide with the picture, probably a little more realistic of what we could see when we catch osteomyelitis. You can see those areas that are circled. Those are the areas where there is an infection present, so that shows up the dead bone tissue on the x-ray. But let's talk about therapeutic management. When we have somebody who has osteomyelitis, we do want to put some limitation on the affected body part. So we would have limitation on weight bearing of the affected body part. So whether that be osteomyelitis that's in the leg or it could even be up in the arm, we still don't want them having any kind of weight on that. Reason being, think about if you've got infection present in that bone, what's it do to the structure of the bone? It changes it, it weakens it, right? So you don't want to have a lot of weight on that because then they're at greater risk for possibly what happening? Hopefully you're thinking a fracture, right? So greater risk for more damage to the bone, and then we've got a whole different issue to deal with. In some cases, they may need to be put on bed rest, especially again if it is occurring in the legs somewhere in those bones, then we may need to require bed rest in order to have that limitation on weight bearing. For your blank right below bed rest, they need immobilization of that whatever bone is involved. So immobilization. Oftentimes they don't want to move it anyway. It's painful, it hurts, they don't want you touching it or coming near it. So immobilization, even if we don't do something to immobilize it, oftentimes they will curtail their own activity and kind of self-immobilize because of the pain that is associated with this. And to treat it, again, if we have bacteria that's present, we need to treat that appropriately. So we give them IV antibiotic therapy, again, indicated by their blood culture results. So oftentimes their antibiotic therapy is initiated in the hospital and then it's continued at home, usually with an intermittent infusion device or a PICC line. And then once they complete that IV antibiotic therapy, they'll typically even be followed by oral antibiotics for another 3 to 4 weeks. So they were really getting some heavy-duty antibiotics for a while. In some cases, if we're not seeing improvement with the antibiotics while they're in the hospital, we may need to talk about doing surgical intervention or drainage. And the only time we really do that is if there's not a response to the specific antibiotic therapy. How are you going to know that they're not responding to the antibiotic? Well, there's a lot of things that we can assess. Vital signs, for one, especially thinking about temperature. If we're on antibiotics for at least 24 hours, we should start to see an improvement. Maybe their fever is not gone, but we should see that fever starting to trend down or improve. So if they've been on antibiotics for 24, 48 hours and we're not seeing much improvement, and again, think about their pain level too, that should be improved if we're improving the infection or clearing up some of that infection. So if we're not seeing some responses in that sense to antibiotic therapy, then we might do some more diagnostic testing and look at seeing if we need to do surgical intervention. So if we do surgical intervention, we want to go in and drain it. Oftentimes what they can do, if pus forms under the peristeum, it can be aspirated. And then after the procedure, sometimes a catheter can be inserted into that area for installation of antibiotic solution. Sometimes, again, a drainage tube may be inserted and then even attached to suction to help extract any of that infectious material that is building up. So, again, we only typically do surgical intervention if we're not seeing that response to antibiotic therapy. An easiest way, vital signs, pain assessment. And I mean, we can look at other diagnostic tests, but those are some easy assessment pieces. So, but they should be on antibiotics for, again, 24, 48 hours before we really see a response to that therapy. Now we're going to move into disorders of the skeletal structure, and we're really going to be talking about scoliosis. So there's different types of scoliosis. It can include kyphosis, lordosis, or what we're going to focus on, idiopathic scoliosis. So kyphosis is where you have outward curvature of the spine. Lordosis is an inward curving of the spine, and idiopathic scoliosis is an S-shaped curve. That is the most common. So again, that's what we're going to focus on is the idiopathic. Scoliosis is usually, again, thinking about the disorder, there's a three-dimensional spine deformity that's characterized by lateral and rotational curvature of the spine. We define scoliosis as there's a lateral curvature of the spine of 10 degrees or more. So it affects the spine in all three planes, the axial, corneal, and the sagittal, and it can involve all or only a portion of the spinal column. So again, you can have something called functional or postural scoliosis. That's typically caused by a secondary problem like a leg length discrepancy, sometimes just poor posture. So think about maybe yourself when you were carrying a lot of books in a backpack. How heavy was that backpack? And if you had to compensate, you tend to kind of sit, or not sit, but I mean kind of lean a little more forward to compensate for the weight. Same thing for kids. They're growing though, right? So they still have a growing spine. And again, sometimes just poor posture when we're sitting. We tend to kind of sit more slouched over. So is more, again, more commonly probably due to other medical issues, possibly like leg length discrepancy, but it can be related again to postural. The one we're going to kind of focus on is more a structural scoliosis, and that's the most common spinal deformity that occurs in or near adolescence, and it's termed idiopathic scoliosis. It's a complex spinal deformity, again, in three planes. So they have lateral curvature of the spine and spinal rotation that causes rib asymmetry. We always look at if there's a family history, so looking for family history of curvature found in up to approximately 30%. Oftentimes there is no specific inheritance pattern though that's documented. It is 5 times more common in girls than boys, and the peak incidence is between 8 and 15 years of age. So think back to growth and development. Why do you think the peak age is between 8 and 15 years of age? What's happening during that time frame, or what's about to start happening oftentimes when scoliosis comes about? Hopefully you're thinking about puberty and that growth spurt that they go through, right? So again, it kind of explains our peak incidence is that's right during those years of puberty and a lot of growth. And as long as the child is growing, spinal curves will become more severe if they would have scoliosis. So symptoms become much more marked at pre-puberty. One of the things that we do is for screening purposes is do what's called the Adams test. And when they do the Adams test, that's where they bend forward. I'll get into that more in just a little bit. The curve actually becomes more noticeable. So here's just an example of what the Adams forward bend test is. It is more commonly used, I would say, definitely in screening during or at school by the school nurse. I remember getting screened back in the middle school years for scoliosis. How much it's still happening today, I don't know since I'm not working in a school. I'm sure in some schools it is happening, but if it's not happening in the school, the other place it should be happening is during those well child visits, right? So again, we do what's called the Adams forward bend test, and that's just where they'll take their t-shirt or whatever shirt they have on off or hanging around their neck, and the physician or the school nurse looking from them from the back has them bend forward and just let their arms dangle in front of them. And really what we're looking for is if there's that bulge. So there's a nice little example of no bulge versus having a bulge. Again, it's not the reliable test, is just a screening tool that we can then refer them on to further diagnostic testing and screening. So screening examinations should be part of, again, at least the well child visits, if nothing else. For females, definitely between at least 10 and 12 years of age. But remember, back in growth and development, we say we even start that at age 8. But that's because puberty varies from age to age when a child will go into puberty. So even though this says at least for girls 10 to 12, it's really recommended even prior to that. It's something that we're looking for even before they hit puberty. For males, ages roughly 13 to 14. But again, we're going to start that probably a lot sooner because we know that males can start their pre-puberty a little bit sooner than that. So this is just another examples of doing, like in the first picture, the one of the girl from front and back, doing the Adams forward bend testing and looking for signs of scoliosis, and you can tell she has a bulge. So that would be a positive screening test, and we certainly would refer her on for other diagnostic testing and referral to monitor her scoliosis. And then the next picture with a little boy where the nurse is actually using something called the scaleometer. That's just used to help document the extent of a spinal curve. A reading that's greater than 7 degrees equals a 20-degree scholastic curve that can be detected by x-ray. And we'll go into more the various curvatures in just a little bit. The next picture, it starts to get into whether you have mild, moderate, or severe, or on the next slide it does. But I'm also going to talk about some of those clinical manifestations that you can see, because you can really see some of those in the next slide. All right, so mild curvature is considered curvature of 10 to 20 degrees. And some of the clinical manifestations that you can see, it's really evident in this first picture of just the single picture of the girl. Look at her waistline, look at her shoulders, look at her scapula, and you're going to notice some of the things that I talk about. So some things that might be reported by the child themselves is that, or maybe even the parent, that clothes just don't fit quite right. They often have uneven hemlines with skirts or dresses. Jeans don't fit correctly, and that's because there's an uneven iliac crest. So again, looking at this picture, you can see, look at the waistline of her shorts. It's very uneven. So imagine if that was a skirt or a dress, and then you looked at the hemline, even though we can't see beyond the waist here, you can imagine, because of that uneven iliac crest, how much that would make your hemline look uneven. They might walk with a slight limp. They may even have unequal leg lengths, right? Because that's contributing, or the scoliosis is contributing to that as well. So unequal leg lengths. They have a malaligned trunk and pelvis, uneven shoulder blades, and a protruding scapula. We can see all of these things on that first picture of this girl from the back. And they have asymmetric shoulders and waistline for your blank. Asymmetric shoulders and waistline. Um, and then there's just another comparison. Probably this was a before and after of the girl before scoliosis treatment, and then I'm assuming what is after treatment. And you can see, even again in that first picture of the girl side by side, she's got protruding scapula. You can see again the curvature. Her waist looks like it's going in one direction, and her shoulders are going in the other. Her shoulders are uneven as well. Again, the protruding scapula. A little bit harder to tell that, like the clothing is sitting uneven, but you can tell a little bit, again, just looking at waist, looks like it's going one direction and shoulders another. I don't actually have a picture for you of moderate curvature, but moderate is considered curvature of 20 to 40 degrees. And severe curvature or severe scoliosis is curvature that's greater than 40 degrees. So you can tell in this picture that I have on the slide, she definitely has a pretty significant curvature. You can see all the things I talked about with clinical manifestations as well, or at least a lot of them that I talked about. What I do want to point out too is getting into diagnostics. When we have somebody with scoliosis, and not necessarily just severe, but with someone who's got scoliosis or we have picked up there's some curvature, we can do different diagnostic tests to really give us the extent of the deformity and give us a full picture and a baseline. So we can do MRIs, X-rays, and CT scans, and those just all help, again, in estimating the extent of the deformity and providing a baseline description. It would also be important, especially in more moderate, probably to severe cases, looking at doing pulmonary function studies and chest X-rays. And even in a mild case, we could potentially need to do these as well. But the reason we want to look at those pulmonary function studies and chest X-rays is if the child has a vertebral rotation causing that rib imbalance, it would be important to document the effect it has on lung capacity. So looking at this child with the severe scoliosis, you could tell that could probably very easily affect her lung capacity. So again, it'd be important to do pulmonary function studies and a chest X-ray just to be able to document that better. We also would do typically bone X-rays. Doesn't matter what, whether it's mild, moderate, or severe scoliosis, we want to do bone X-rays, and that helps to determine the bone age and our course of treatment. So if bone growth is almost complete or is complete and the curvature is less than 50 degrees, we don't typically do any sort of correction. If they're almost done growing, that curvature is not going to get any worse. We're more worried about the child who has 1 to 2 years of bone growth remaining. They're going to get some form of correction. And again, that's going to be individualized for the child and depending on the severity. But if they still have a little bit, or not a little bit, a good amount of time of growth left, we want to make sure we're doing some sort of correction in order to prevent further curvature from occurring. So this is just another example of severe scoliosis, really comparing a probably before and after any sort of intervention, and x-rays, what those look like beforehand. So the first picture of this, she has pretty severe scoliosis. You can really see that S-shaped and a lot of those clinical manifestations that I already talked about. And then she obviously had rod placement done for her scoliosis. And you can see she's still got some curvature, but not nearly as severe. So it has improved her curvature in the sense we're never going to get it back 100% straight, but we certainly want to prevent it from getting worse or causing other problems. Right. Moving into talking about therapeutic management, again, it just depends on how severe the curvature is as to what we're going to do. So if it's a mild curvature, less than 20 degrees, no therapy is required. No therapy required. We're just going to do close observation and x-rays every 6 months until the child reaches, what do you think? Growth maturity, right? Really looking at those wrist x-rays or those bone x-rays to determine if bone growth is complete. So for your blank, the child reaches growth maturity. They're done growing. We'll just closely observe them. If they have moderate curvature, greater than 20 degrees, treatment can actually consist of more conservative approach, a non-surgical, conservative and non-surgical approach by using a body brace. I'm going to go into that further. And that's really where we're going to focus is the moderate curvature and using a body brace. In some cases with moderate curvature, they can also include surgery or a combination of both surgical and non-surgical measures. With severe curvature, so greater than 40 degrees, they may actually require surgery with spinal fusion or putting in different rods and pin placements to create a more stable spinal column. Regardless if we do more conventional treatment measures or we do surgery or we do a combination of those, the goal of both surgery and mechanical bracing is to maintain spinal stability, and really prevent, the other piece of that is prevent further progression of the deformity until bone growth is complete. So until the child's done growing, which this treatment measures, regardless of what we do, could be years of follow through and treatment to make sure that there isn't further progression and deformity. So again, we're going to do that until bone growth is complete. So again, child and family need to understand this is long-term treatment, especially depending on how old they are. Say they were in it could be pre-adolescence and pre-puberty, right at the beginning of that bone growth with puberty occurring. This could be really long-term, years of treatment and follow-through that we're looking at. So again, think about too, with pre-puberty and adolescence, how concerned they are with body image. They don't want anything to set them apart from their peers. They very much want to fit in. And unfortunately, sometimes with having scoliosis or going through the treatment measures, that makes them different. And they certainly don't like that. So the other piece of that is the psychological side of it. They need a lot of support and helping them deal with whatever that treatment is, or again, how this sets them apart from their peers, because the last thing we want them to be is non-compliant with whatever the treatment measures are. So we're going to focus on moderate curvature or treatment, which is using a body brace. I just like to keep this one in here. This is actually the first type of body brace that was used for treatment of scoliosis, and it was called the Milwaukee brace. Kind of looks like a torture device nowadays. In the next slide, I'm actually going to show you what modern bracing looks like. But we use bracing for slight curvatures, especially in the child who is still skeletally immature, meaning they're still growing. So again, this was just the first brace. We don't use this anymore, but it was called the Milwaukee brace. This is today's version of bracing. This is called the Boston brace, or a TLSO brace is what we use now. Definitely very different from the first one I showed you. It's meant to fit under clothing, so it can be hidden by different clothing that they wear. So again, that they don't stick out to their peers. But there's a lot of compliance with using this. So this is called a TLSO brace. It's important that the child is instructed to wear this brace for 23 hours per day, right? So it's really only supposed to be removed for showering or participating in structured athletic programs, an example like soccer or whatever sports maybe that they're in. Other than that, they need to wear this all the time, because the point of this bracing is to prevent further progression. It's not going to fix the curvature that's already there. We're just trying to prevent it from getting worse. So for the child to have to wear this 23 hours a day, who maybe doesn't want to stick out from their peers, you can hide it under clothing all you want. All it takes is for the a peer to accidentally bump into them, or even like watch them sit down in a chair, because look at how far this comes over the hips and the pubic bone. This child's going to have probably the best posture ever in the class. So even though we can hide it with clothing to a certain extent, it still makes them feel very different from their peers, and they don't want that. But again, it's important to make sure they understand that compliance is really important, because otherwise it's not doing its job if they're not wearing it, or it's not being worn the correct way. So again, they should be wearing it 23 hours per day. At night, in some cases, they can be prescribed what's called a Charleston bending brace. It confines the spine to an overcorrected position. It might be a little bit more comfortable to sleep in versus this brace. This is a hard plastic kind of material, so it doesn't allow them, obviously, to have a whole lot of movement. Important to make sure child and parents know how to safely apply the brace, and that they're going to need frequent follow up visits to check to make sure the device fits snugly without rubbing over those bony promises. So make sure we're cautioning children and parents not to loosen those straps if they feel rubbing, because that really defeats the purpose of the brace. The brace is meant to fit snugly so that, again, we're preventing further progression of that curvature by loosening those straps because something is rubbing. Then the brace is fitting loosely. So then it's not allowing for that proper compression and traction that it's really providing. So advise parents and child to just notify the healthcare provider instead, and they can make adjustments so that it's not rubbing. The other really important thing is to try and prevent skin breakdown. They must wear a t-shirt under the brace to prevent the plastic pads from touching the skin surfaces and causing skin excoriation. So they need to be wearing a t-shirt underneath the brace. And then, if they want to put like a sweatshirt or another shirt on over it to cover it, that is fine, but they must wear a t-shirt underneath. And especially during those first couple of weeks when they're really trying to adjust to wearing this brace, children tend to notice that they have some slight muscle aches, and that's just resulting because they're in a straighter back alignment than what they were accustomed to. They don't need anything real fancy in the sense for their slight muscle aches and pain and discomfort. Just a mild analgesic like acetaminophen can help decrease their discomfort. It's also best to just recommend rest. That can provide considerable amount of relief. So just changing positions, laying down, sitting up, maybe in a more reclined position might be helpful. Also caution children not to remove the brace during this time because taking it off really compounds the problem of discomfort and it really prolongs that period of adjustment. So we want them to keep it in place even and work through those discomforts of getting adjusted to a new brace. With more severe scoliosis, that's when we really get into doing more surgical procedures and other methods. We could use the halo traction method, which is really just use of opposing forces to straighten or reduce that spinal curvature, especially if it is severe when they're first diagnosed. I don't want you to focus so much on this. I still like to leave it in there because it's just kind of some nice information that, how do we manage someone who has severe scoliosis? So halo traction can be used, and oftentimes with the halo traction, they do have pin sites to provide that contraction. So there's pins placed in the distal femurs or even the iliac crest, and then they can do halo traction until they feel like optimal spinal correction is achieved. So again, thinking about pin site care, analgesics for their pain at pin sites and their back pain, especially in the first 24 hours. Other methods that we can use for severe scoliosis is doing more surgical intervention, the spinal instrumentation. So using rods and screws, which is what's an example in these one picture, as you can see that rod that's been placed next to the spinal column, and that helps to provide a firm reduction of the curvature. And then the spine is also then fused into corrected position. The disadvantages of using spinal instrumentation is it really prevents further spinal growth in that areas where spinal fusion has taken place and where rod placement has taken place. Our next disorder we're going to talk about is getting into disorders of the joints and tendons. We're going to talk about juvenile idiopathic arthritis. It can also be referred to as juvenile arthritis or juvenile rheumatoid arthritis. It is an inflammatory disease causing, guess what? Inflammation of the joints and other tissue. So it primarily involves the joints of the body, although it can affect blood vessels and other connective tissue as well. So for it to be juvenile arthritis or juvenile idiopathic arthritis, symptoms must begin before 16 years of age and last longer than 3 months. slightly more common in girls than boys. The exact cause is unknown. There's thought to be an autoimmune process where the child develops circulating antibodies or immunoglobulins against the body's cells, and then revealed by the presence of the anti-nuclear antibodies in the bloodstream. There could be a genetic predisposition that may be present as well and just increases the risk in some children. But ultimately, we really don't know why this is caused in younger children or in children. Assessment wise, they're usually brought to the healthcare facility because they've been having persistent fever and rash. So, for your two blanks, persistent fever and rash. These symptoms are present even before the pain and the stiffness of the joint involvement begins. So, what we typically think of with arthritis is that pain and stiffness. So, before those typical symptoms start, we'll actually see the persistent fever and rash. Regardless of the type of juvenile arthritis, it's important to assess children for the effect that the disease is having on their self care. So, thinking about eating, dressing, ambulating, toileting, all those things we think about with arthritis. Assess the child and parents' understanding of the illness and therapy that's planned. Typically, they bear the majority of the major responsibility of evaluating further symptoms and for carrying out the therapy at home. So that's mostly going to be, again, it depends on time of diagnosis, but that's going to be more reliant on the parent making sure that even if it is an adolescent, that they are following through. So again, just depends on age of time of diagnosis, but symptoms must begin before 16 years of age and last longer than 3 months. Some general symptoms that tend to occur with the juvenile idiopathic arthritis are just like what you would see with arthritis for the adult. So they have swelling or effusion. So we can see that in this picture. If you look at the fingers, there, especially that middle finger, is more swollen. So swelling or effusion is present. Limitation of range of motion. So limitation of range of motion, again, because of that pain and joint stiffness. There's tenderness present, pain on motion, and it's often warm to the touch. Warm to the touch. So therapeutic management for juvenile idiopathic arthritis. That therapy includes a balanced program of exercise, rest, and medication administration. Our goals to therapy are to do what with the pain? Well, ideally, we want to relieve that pain, right? So, for your blank, relieve pain. What do we want to restore? We want to restore the function, right? So, that range of motion, restore function. And then the last goal is to maintain joint mobility. So, your 3 goals to therapy: relieve pain, restore function, and maintain joint mobility. Our next therapeutic management is talking about daily activities and exercise. So we may need to modify some things to make it easier because of that limited range of motion. And again, how much is it affecting their self-care? So maybe using use of elevated toilet seat to reduce the amount of bending that's required at the knee. Use of loops and Velcro strips to make it easier to dress themselves and increase their overall level of activity despite the joint involvement. Oftentimes, there's a prescribed set of programs of daily range of motion exercises, and those are designed to strengthen muscles and put the joints through their full range of motion. Potentially, it's to help preserve muscle and joint function. It's best if it's incorporated into like a dance routine or a game because that makes it more enjoyable for the child. It can make the exercise a family participation and more of just a fun experience versus like, I got to do these exercises, right? Swimming and tricycle or bicycle riding are excellent ways to get joints moving because those provide smooth joint action. It also doesn't put a lot of pressure on different joints, like running would put a lot of pressure from constantly pounding those joints from running. We want to encourage as much self-care as possible because dressing and brushing the teeth also exercise the joints. So again, encouraging that self-care. Activities, again, that place that excessive strain on joints should be avoided. So running, jumping, prolonged walking, kicking, put that excessive strain on the joints. We want them to continue to attend school as best as possible. In some cases, depending on the severity, it can really affect their ability to go to school and be involved and concentrate, because if they're having a lot of pain or having a lot of joint stiffness, that can make the school day difficult. So, because it increases that activity, hopefully it leads to fewer contractions and less uh, decalcification of bones. But sometimes they also need to have a modified day. So, children who have juvenile arthritis often fatigue easily as well. So, they might need that shortened school day, maybe move their start time to mid morning, because that would allow the child a little more time to kind of get up and get ready, kind of get those joints working a little bit better or moving better. It gives them an opportunity maybe to soak in a warm bath in the morning, which can help reduce pain and increase movement in the involved joints. Heat application is another method of therapeutic management that we use. Heat actually reduces pain and inflammation in those joints. It helps to increase the comfort and motion as well. Applied use of heating pad or warm water soaks for about 20 to 30 minutes can help with that pain and inflammation. We can also try paraffin soaks. Those can be useful for wrist and finger inflammation. It is important to caution parents of young children that frequently play with the controls on a heating pad. So, um, either they need to be supervised while they're using it, or really one of the best things they can do is tape that control to the medium temperature to help guard against burns, so that they're not playing with it, turning it up. They don't need super hot heating pad, just the medium temperature control. And our last therapeutic management that we're going to talk about is medications. So, just like the adult, our drug of choice is what? NSAIDs, right? So, NSAIDs are our drug of choice. So, ibuprofen or naproxen, because those help control pain and what's been going on. What's our pathophysiology? We have inflammation, right? So, it helps control pain and inflammation. It can reduce joint swelling, joint discomfort, that morning stiffness. It can contribute to the improvement of malaise and irritability that they're experiencing as well. It would be important to make sure they're taking it 4 times a day, so QID, for at least 6 to 8 hours to ensure effectiveness. It can be given with food, especially if it is causing GI upset. It should be given with food to try and avoid that GI upset and bleeding. Let me rephrase that. So, give with food to avoid GI upset and bleeding. There are some other drugs out there, but NSAIDs are our drug of choice. That's what I want you to know for testing purposes. I still like to leave the other ones in there because there are other treatment measures that we can do. There's the slow acting anti-rheumatic drugs. There's methotrexate, which is actually a cytotoxic drug. That is usually the second drug that's prescribed, either if the NSAIDs weren't enough or maybe in combination with it. But again, our first line defense is to go to NSAIDs. And in some cases, depending on how severe the inflammation is, we can actually do steroids like prednisone. Um, that can be added to drug therapy, especially the extremely severe, or if it's incapacitating the systemic system that has not responded to other anti-inflammatory agents, we can add on steroids. We're going to start talking about disorders of the skeletal muscles now. And the first one we're going to talk about is muscular dystrophies. That is the largest group of inherited muscular disease in children, and it leads to progressive degeneration of the skeletal muscles that control movement. So there's gradual degeneration of muscle fibers, which leads to progressive weakness and wasting of skeletal muscles. There are different types of muscular dystrophy. We're only going to focus on one because that's the most common form that we see. And the one we're going to focus on is Duchenne muscular dystrophy. Again, it's the most common form of muscular dystrophy. It's also the most severe and the most common of the muscular dystrophies in childhood. It's an inherited sex-linked recessive trait, which means it only occurs in males. Symptoms are usually apparent by 3 years of age, and life expectancy reaches into early adulthood. The clinical manifestations that are seen with Duchenne muscular dystrophy, there's usually a history of meeting motor milestones, those developmental motor milestones like sitting, walking, and standing, they reach those milestones just a little bit later than the average infant. By 3 years of age, those symptoms become acute and obvious. They develop a wide-based gait. They start having difficulty climbing stairs and frequent falls. And what this slide is portraying is what's called the Gower sign. And that's where the child turns onto their side or abdomen and they'll flex their knees to assure they're in a kneeling position. And when the knees are extended, they'll gradually push their torso to an upright position, basically by walking their hands up their body. So, if they're down on the floor, they can't just pop up like a normal child because of that muscle degeneration. It's much harder for them to get to a standing upright position. So they'll get on their hands and knees, and then they'll literally walk their hands up their body to get to a standing position. What you'll also notice in one of these pictures is once he's in the standing position, look at the curvature in his back. He has lordosis. So your blank on the top of page 13 is lordosis is present as well. They tend to also walk on their heels, or not on their heels, walk on their toes, which will lead to them developing what's called short heel cord. So because those muscles are contracting, because they're not getting stretched across the heel, when they walk on their toes, they develop what's called a short heel cord. They start to have problems with speech and swallowing. Those become more difficult, again, as we get into further progression of this disease. The calf muscles will become hypertrophied, and that's just because the muscles become so degenerated that they are actually replaced by fat and connective tissue. Their mobility will generally start declining because their general muscle strength declines over time. And they have progressive muscle weakness, wasting, contractures, and even fractures can occur. Again, I already said the blank on the top of page 13 is lordosis. Again, we can see this in this picture about the Gower sign. Usually by junior high school age, they have become wheelchair dependent because, again, those muscles have just become too degenerated. They've lost a lot of their muscle tone and strength in order to be able to walk. They also end up having tachycardia, and that's because the heart is a muscle itself, and that weakens and enlarges over time as well. Pneumonia can also develop easily. A lot of that is because that cough reflex becomes weak and ineffective, leading more likely to upper respiratory infections, which could lead to lower respiratory infections or pneumonia. Their heart and muscles that are used for respirations are affected late in the disease, and death usually is a result of pulmonary dysfunction that occurs. So somewhere in their early to mid 20s is typically what, again, their life expectancy would be. When it comes to diagnostic evaluation, we really want to do a history and look at their physical findings. We can do muscle biopsies, and that'll just show us the fibrous degeneration and any fatty deposits that are present. They can do electromyography, which will show you a decrease in their amplitude and the duration of the motor unit potentials. They also tend to have an increase in their serum CK levels. They're significantly high, and we would want to certainly, we don't have to require it, but certainly suggest doing a genetic analysis. Again, it's only males who are going to get it, but what if they have a sibling who's a female? It's a sex-linked recessive trait. So even though the female is not going to present with symptoms or have the disease, a female sibling could actually pass that on to her offspring at some point. So genetic analysis would be important to certainly recommend and explain why that would be so important. The therapeutic management for Duchenne muscular dystrophy, there is no effective treatment that's established. It's mostly supportive care. So for your blank, supportive care. Our primary goal is we want to maintain function in those unaffected muscles for as long as possible. And our secondary goal is to prevent contractures. So prevent contractures. We want them to remain ambulatory for as long as possible. We want them doing active and passive daily range of motion exercises. and use splinting and bracing to maintain lower extremity stability and help avoid contractures. We want to encourage a low calorie, high protein diet to avoid excessive weight gain. Um, in order to prevent constipation because of that poor abdominal muscle tone. And again, thinking about too that, as we have further progression in this disease and they're becoming less mobile, constipation can also become an issue. So, high intake of fiber and fluids can help with constipation, stool softeners as necessary as well. Can sometimes do corticosteroid therapy that can be helpful to increase the function and strength of muscles on a short term basis. So, parents would need to have a very set schedule of administration if they are on that therapy. And again, we recommend genetic counseling for the family. Our nursing care management is really centered around helping that child and family cope with this chronic and progressive and debilitating disease. So, teaching the child as many self help skills as possible and really encouraging them to do as much of their self care as possible to keep them active. Encourage parents to seek a support group because, again, there is no cure for this. So, help them to be able to deal with those feelings of having such a chronic, debilitating disease. And then there's lots of teaching. We need to teach about the different use of medications that whatever the child may be on at the time, use of respiratory drugs, antibiotics, stool softeners. We want to make sure we discuss very realistic and long-term and short-term goals, right? So since there is no cure, making sure parents have a realistic understanding for long-term and short-term. Continue those regular well-child visits and, of course, keep up with immunizations. Immunizations, again, keeping up with those is really about prevention of other illnesses that could complicate this because, again, as things progress and the respiratory system is not as functioning as well because of those muscles, we would really like to try and prevent different infections. And keeping up with those regular well child visits is, again, going to allow for the parent to ask questions or modify our care or get medications that they may need as this disease progresses. Moving into fractures. Fractures, you should be familiar with that. I'm sure you've talked about that in previous med-surg classes, but fractures are just simply a break in the continuity or the structure of the bone. For children, though, who experience falls during their growth years, fractures of long bones are very common in childhood. Those are common childhood injuries. Fractures tend to be different than adults for children, and that's because the bone in childhood is fairly porous, so it allows bones to bend rather than break. The peristernum is thick, so the bone may not break all the way through. Epiphyseal lines may kind of cushion a blow so that the bone itself does not break. And healing is rapid as a result of the overall increased bone growth that is occurring in childhood. Many fractures in early childhood are actually considered of the green stick variety, which causes minimal pain, swelling, or deformity. And the usual hallmarks of a fracture. So there are different types of fractures. You do not need to know the different types of fractures. I'm not going to ask you what's a bend, what's a buckle versus a green stick or a complete. I left those in there just because I want you to understand there are different types of fractures, but I am not going to quiz you or test you on the different types of fractures. So moving into epiphyseal injuries. Epiphyseal injuries, again, part of fractures, they actually affect future bone growth. And again, epiphyseal injuries are a part of those growth plates. So if we would fracture through or into that growth plate, that can certainly lead to that future bone growth affecting it. It could lead to undergrowth, overgrowth, or an uneven growth, which is oftentimes when children need bone lengthening or bone shortening procedures later in life to make sure that they do have equal and adequate bone growth. Epiphyseal injuries are also frequent sites of damage during trauma, so like motor vehicle accidents or potentially sports injuries, depending on where the blow was from the trauma. Treatment may include open reduction and internal fixation, or often referred to as an ORIF, to prevent that growth disturbance. Assessment-wise of epiphyseal injuries and fractures. The hallmark signs of an injury are deformity, pain, and edema. If a fracture is suspected, then a splint to the extremity, or we should splint the extremity to try and avoid further trauma or damage to that. It also helps to reduce pain because it prevents further movements of the bone. The splint should extend from the joint above to the joint below the suspected fracture site. And we would want to get a thorough history of the injury. So some fractures could occur because of child maltreatment, right? So those would need to be ruled out or for any unintentional injuries. And then our therapeutic management and goals. We're going to do an x-ray to confirm diagnosis and really to help us to determine alignment and appropriate position. If the skin over the fracture site is broken, then we may need to do like a tetanus booster or tetanus prophylaxis, give IV antibiotics, again, trying to prevent infection from occurring. We can get a hematocrit for determination if there was a lot of blood loss or estimate the blood loss. In some cases, maybe cross-matching for replacement therapy if it's needed. They're going to need IV for fluid and again, potentially for blood replacement if there was a lot of blood loss or for antibiotic therapy. Our whole goals when we're doing therapeutic management for fractures is we want to realign and length of the bony fragments. We want to retain alignment and length, or basically create immobilization. We want to restore function to the injured parts and prevent further injury and deformity. Most fractures can be treated with closed reduction and use of cast immobilization that we talked about in the beginning of this chapter. Our nursing care. We would want to get, a history and physical using a calm, quiet voice because the child's probably already scared, they're in pain, so you wouldn't want to, rush up to them or be real anxious. Just approach them in a calm manner in order to kind of find out what's been happening, where it's hurting, where is it hurting, what's it feel like, to really get a good picture of what's been going on. So approach them with a calm, quiet voice. We want to stabilize that injury to avoid any unnecessary movement. So, again, not being in a hospital, let's say you're at home and your child, or maybe you're at a party and the child falls off of a couch or furniture, jumps off a swing set and lands wrong. Or maybe you're the school nurse and you get called out to the playground because the child has somehow fallen and hurt themselves. We would want to be careful and try and support and immobilize that extremity. So I don't know too many people who walk around carrying splints in their back pocket or their purse, but we can use different items like splinting with pillows, using some sort of hard splint device. We can even take rolled up newspapers or magazines to create our splint. So there are different ways that we can try and immobilize that extremity. We also would want to elevate the limb and apply ice. Again, that's going to help with any inflammation and swelling that's occurring. Big important piece, you need to be assessing neurovascular status of that injured extremity. So think about your 5 Ps. And of course, pain management, providing an analgesia for their pain and comforting the child and parent. Our last couple topics we're going to talk about actually come from chapter 27, and that's the child born with a physical or developmental challenge. Our first topic we're going to talk about is tapalis disorders, or often referred to as club foot. Those are deformities of the ankle foot. So there's deformity of the bone with malposition that results in contracture of the soft tissue of the foot and ankle. It occurs in 1 in 1,000 live births, more common in boys than girls, and it probably has an inherited is an inherited polygenetic pattern. It usually occurs unilaterally, however, it can occur bilateral in some cases, and there are different types. We're going to focus really on one particular type when it comes to like your study purpose and method or testing. So there's different classifications. You can have positional, or what's often referred to as pseudotapalis, which just often occurs, I'll get it out, or occurs because of intrauterine crowding, so just the way that they were positioned. And in those pseudotapalis disorders or positional clubfoot, the foot can actually be brought into a straight position by manual manipulation. So it'd be important to assure parents that it can easily be brought back into line and it's not really deformed. It's just the way that they were sitting in the uterus, maybe a little cramped in there. Just simply doing some stretching of the foot every day will solve that problem over time. The one we're going to actually focus on is congenital or idiopathic, which is considered the true clubfoot. This is when the foot cannot be properly aligned without further intervention. So in this picture, or this slide, it is showing congenital clubfoot. Happens to be one that is bilateral. Again, it can occur most commonly as unilateral, but in some cases can occur bilaterally. So assessment-wise, the earlier a true disorder is recognized, the better, and that's better for correction. So with a newborn, it would be important to make a habit of straightening all newborns' feet to midline as part of that initial assessment in order to detect the disorder. Again, with congenital or true clubfoot, the foot wouldn't be able to be properly aligned. If it was the pseudotapalis, you would be able to manipulate that foot into alignment, into a straight position. So with congenital clubfoot, you wouldn't be able to straighten it, but it's important to try and detect that by making a habit of trying to straighten all newborns' feet. If there's a possible deformity, then we would want to refer them on to the pediatric physician or an orthopedic specialist to begin that process of evaluating the infant. And the reason it can't be straightened again is because it involves the bone. It's not just soft tissue. So it would need further intervention in order to correct it. So our therapeutic management for congenital clubfoot is best if correction is achieved, if it's begun in the newborn period. So for correction, what we'll do is a series of casts or braces that are applied, and that gradually molds the foot into good alignment. So we call this the Ponseti method or the serial casting method. So casting or again the Ponseti method. The cast or brace will extend above the knee to ensure firm correction. And with serial casting, or again the Ponseti method, it's begun immediately or shortly after birth, typically in that newborn period. And the frequent casting or brace adjustments are done to accommodate that rapid growth of infancy. So usually every 1 to 2 weeks, they will have those casts changed out, or if they're in braces, the brace adjusted. They're casted until maximum correction is achieved, and that can usually take about 6 weeks. And then so it would be important to teach the parents about cast care. So again, there in this picture, it's just showing an infant, the bottom picture, an infant who has bilateral clubfoot where they have casted. Again, notice that the casts go up above the knee. And the top picture is just showing the series of casts, how we go from the beginning to hopefully full correction by the end. And how many casts they go through, how frequently, again, is going to be individually based on the child, but typically they will do what we call the serial casting and change those casts every 1 to 2 weeks. After we're done doing the serial casting or using the Ponseti method, once they're done with casting and we've achieved correction, we now want to maintain that correction. So in order to do that, they'll use what's called the Denise Brown splints, and they look like little high top shoes that are worn at night for several months, and that's just to maintain that position and effective correction. It is important that parents perform passive foot exercises, putting that infant's foot and ankle through a full range of motion several times a day for several months. Very important to stress that, again, so that we don't have other issues coming up with contractures and things like that from being in cast and these splints. But really important that they wear these splints, whatever's prescribed, if it's just at night or for so many hours a day. Again, that's going to maintain the proper position that we want. Prognosis overall, they, for the most part, very good prognosis. They can get full correction is pretty good by doing the casting method or the Ponseti method and then following up with the Denise Brown splints. In some cases, children who can't achieve full correction by casting, they may need to do additional surgery. as another way to get final correction. This slide is just an example of what can happen thinking about mobility and just the deformity of the foot if we let clubfoot go untreated. You can really tell her foot is really has some deformity to it. It's definitely turned in. Think about how that would affect the ability to walk and be able to get around. You couldn't really wear a shoe on that foot. And just thinking about for kids, they tend to stare, and it, again, sets them apart from their peers. The last disorder we're going to talk about is developmental dysplasia of the hip, or often referred to as DDH. It's also formally called congenital hip dysplasia, and it's where you have an improper formation and function of the hip socket. So it's the leading cause of orthopedic disability in children and adult life. It can lead to premature arthritis and even lead to hip replacement. What ends up happening, and I'm going to kind of explain the pictures on this slide, is the acetabulum of the pelvis is unusually flattened or shallow. Because it's so flattened or shallow, it then prevents the head of the femur from remaining in the acetabulum and rotating adequately. So in this slide, like the very first picture, it says normal. That's what it should look like. And there's different variations or degrees of DDH. So you can have dysplasia, where you can see the acetabulum is a little more flat and shallow. And what happens is that means there's more risk for that femoral head to come out of the joint or potentially have problems. It's not out, it's still in contact, but it would be a lot easier depending on the laxity of tendons. It could slip out of that joint a little bit more easily. So we want to diagnose it early when it is dysplasia so that we don't get into subluxation and dislocation. So subluxation, with the difference of that, is again where you have laxity of the tendon itself, so it's actually starting to come out of that hip a little bit. The femur rides up because of that flattened acetabulum, where dislocation, the femur rides up so far it actually leaves the acetabulum. So it's completely out of that hip socket joint as well. So kind of going back and just talking about some other things that are in your notes, it's 6 times more frequently seen in girls than boys. It typically is unilateral, and the exact cause is unknown. There are different risk factors related to breech birth, again being a female infant, mother's first pregnancy, if there's a family history of DDH, oligohydramnios, which means there's a lot of fluids or a lot of fluid during pregnancy. If there's a large birth weight for the gestational age, torticollis is another one, and the metatarsus adductus are other risk factors. Again, so there's different types. You can have dysplasia, subluxation, or dislocation. Obviously, the more progressed it is, just depends on how flat and shallow that acetabulum is and the laxity of our tendons and how much it will kind of have movement and possibly slip out of the joint itself. So assessment for developmental dysplasia of the hip, we screen all infants for developmental dysplasia of the hip from birth up until 3 months of age. And we use something called the Ortolini-Barlow maneuver. In a couple slides, there's a couple videos that kind of talk through a little bit more about that, and I will talk through it a little bit as well. But we use that to detect DDH in the newborn because it's important, because the longer the condition goes undetected, the more difficult it is to correct. So on inspection, and some of these things you can see in some of these pictures as well, like picture A, the very next piece I'm going to talk about, the affected leg actually may appear slightly shorter than the other, and that's because that femoral head is riding so high in the socket. So again, we can see that there is a leg discrepancy on picture A, as well as it's most notable when the child is lying supine and the thighs are flexed to a 90-degree angle towards the abdomen. That causes one knee to be lower than the other. So that's what picture C is demonstrating on this slide. And sometimes we can see an unequal number of skin folds. may be present on the posterior thighs. So again, picture A is showing that as well. This finding, though, is not always reliable. Sometimes you just have some chunky little babies. So just because they have extra skin folds does not equate that they have DDH necessarily. We look for other things. So again, they could have an unequal number of skin folds that can be present on the posterior thighs. And then we look to see, again, subluxated or dislocated hips are best assessed by noting whether the hips abduct, adduct. And again, that's really when we're getting into the Ortolini and Barlow maneuvers, which is really what's showing picture B and D is about. Picture E is for an older child. If it would go undiagnosed, we can use something called the Trendelenburg sign and seeing and looking for lordosis. For purposes of testing, we're not going to get into that because most commonly we do find this in the newborn period and would start treatment. So this picture is just showing you, even though it's not from posterior, we're seeing those extra skin folds compared from one side to the other. And the picture's a little bit cut off, but you can tell one foot or one leg is a little slightly shorter than the other. So this is just showing some actual symptoms that we've talked about on a real child. So diagnostics for DDH. Again, we primarily use what's called the Ortolani and Barlow's test. So for your blanks, Ortolani and Barlow's test. And our current guidelines recommend that a physical exam screening is done for all infants up to 6 to 12 months of age during their primary care visits via the hip assessment and doing continual screening of those with the risk factors until their walking age. There are some radiologic screening current guidelines recommended. Again, you don't need to necessarily worry about those for studying. It's just a little more detail what they can do and kind of what those guidelines are, but don't worry about them for study purposes and testing purposes. I want you to understand what signs and symptoms we would look for, and of course that we would use the Ortolani and Barlow maneuvers. Well, we would not be performing those, the physician would be performing those. If you watch the hyperlink that says the example and explanation of Ortolani Barlow test, it's kind of a dry video, but the guy does a really good job showing you and explaining what the Ortolani Barlow maneuver is and demonstrating not only on a simulated hip of a infant, but also then at the end it will show you a video of doing the actual exam on an infant. So it's about a 2.5-minute video. The other one that says video for hip dysplasia, that's just kind of a nice overview. It does a good description showing an actual infant and kind of from a family perspective of how the infant was diagnosed and what hip instability is or hip dysplasia is, and then how we treat it. So it's just kind of a nice little overview. It's a video from Mayo Clinic as well. Our therapeutic management for DDH, our current recommendations, they may suggest just close monitoring in those mild cases. In more severe cases where it can adversely affect the normal hip growth and development and concerned about issues later in adulthood, those infants that are less than 6 months of age are usually treated by using a flexion abduction splinting device, which is what we're going to talk about and is in this picture is what's called a Pavlik harness. It's probably the most commonly used one. There are other methods to achieving the same thing. But what that does, especially we use that for infants that are less than 6 months of age, and they're usually treated again by using this flexion abduction splinting device. It involves positioning that hip into a flexed and abducted position. And what that does is it presses the femoral head against the acetabulum, and it causes that acetabulum to actually deepen and contour from that pressure. So really over time, it's creating better stability of that hip socket joint. So again, for newborns to 6 months of age, we're going to use what's called the Pavlik harness, which is what I have in these slides. Again, Pavlik harness for abduction of the hip. So it's a non-invasive device that actually keeps the hips in an abducted position continually in order to stabilize that femur into a normal position flexed within the acetabulum. The infant will typically wear the harness continuously for 3 to 4 weeks. If you watch that video, I think it tells you 6 weeks. But what I want you to understand is Pavlik harness is what's most commonly used. Again, we're going to look at it on an individual child basis as to how long they need to wear it. But they do wear it continuously for several weeks. The family does need to be taught some care in regarding safe use of the harness and how to prevent skin breakdown in the infant. So they need to make sure they're wearing a t-shirt or a onesie on under the harness to protect the skin. What I don't like about either one of these pictures was the fact that it shows it directly applied to the skin. That is not true. We do not want to do that. They should have some sort of t-shirt or onesie on under the harness to protect their skin, as well as they should have like little socks or booties and those stirrups as well to protect that skin where the straps are around the foot and the lower portion of the leg. We want to make sure parents understand to massage the skin under the harness frequently and to assess for skin breakdown. We never want them using lotion or powder under the harness because that actually causes friction and then leads to skin breakdown. So never use lotion or powder under the harness. When we think about the nursing care, again, whether most oftenly in this case we're using the Pavlik harness or some sort of a harness method. In some cases, they may go to doing a casting method, but the harness is a little less invasive and it's not as uncomfortable. You can see from that previous video or the slide in the previous video, I'll get it right, from the video in the previous slide, how she was able to kind of move around very easily, where a cast is going to be a little more restrictive. Not painful, just more restrictive. But some things to keep in mind. Because of rapid growth, those straps should be checked at the beginning of therapy and every week for adjustments. Because again, if we're in the newborn to 6-month period when we're using this, that infant is having rapid growth. So they would need those straps adjusted on a frequent basis. And the parents should never adjust the harness themselves. That should be done by the doctor only. And again, going back to the skin care and the harness care, always put that undershirt or t-shirt or onesie on under, especially those chest straps, and put knee socks or knee-high socks under the foot and leg pieces to prevent rubbing of the skin. Checking frequently for any red areas under the straps and the clothing. Gently massage the skin once a day just to stimulate circulation. Avoiding lotions and powders because those can create an irritant and friction to the skin. And always place a diaper under the straps as well. Parents are still encouraged to hold their infant just like they would normally and to bond with them.